section of this discipline. Without further ado, let us eagerly anticipate the valuable insights on the clinical use of the common ophthalmic drugs in dogs and cats. She is about to share with us. Please join me in welcoming Dr. Chongpuru Pernkamp to the presentations, and please give her a big applause.
Okay. Good morning, everyone. I'm very the honor to be here as a speaker. And thank you for the very nice introduction of our moderator today. And today, my topic is talking about the clinical use of common ophthalmic drugs in dogs and cats. And this is my outline of presentation today. I will start with a little bit of the introduction of ocular pharmacology, focusing on the ophthalmic drug barriers that affect the efficacy of the drug in the use of the eye. And then we'll move to the routes of ophthalmic drug administration. Which route should be used for the certain part of the eye. And the last one, I will talk about the clinical use of ophthalmic drugs based on the commonly found cases in veterinary practice. From our basic knowledge, the eye has the three layers, which are the outer protective fibrous coat, which consists of the cornea and the sclera, the middle part of the vascular layer consisting of the iris, ciliary body, and choroid, and the innermost layer of the neural tissue comprised of the retina. The treatment strategy for ocular diseases can be especially challenging because of these ocular barriers presented. The ocular barriers can be classified into the anatomical barrier and the physiological barriers. The anatomical barrier, including the cornea and the blood ocular barrier, is composed of the blood aqueous barrier at the iris and the ciliary body, and the blood retina barrier at the choroid and the retina. And all of these can make the target to choose how to reach to the therapeutic levels of the drugs. In addition, there are also the physiological factors such as the tear film and mesenchymal duct drainage that also regulates the drug absorption. So let's begin with the first anatomical barrier, which is the corneal barriers. The cornea is a transparent trilaminar structure that protects the innermost layer structure of the eye. It is comprised of the hydrophobic multilayered epithelium, which contains a tight junction between the apical cells, a hydrophilic stroma, and a hydrophobic endothelium with its specialized basement membrane called the Descemet membrane. Therefore, for a drug to have optimal bioavailability, it should have the right balance between the lipophilicity and hydrophilicity. The pictures on the left depicts the barrier of the intact corneal healthy eyes on the left, but in this diseased eye on the right, the barrier is disrupted and therefore enhance the systemic absorption from the greater conjunctival vascular permeability or the reduction in the ocular drug bioavailability due to the drug albumin interactions in the tear film. The second one is the blood aqueous barrier. It is the barrier between the non-pigmented epithelium of the ciliary body and the endothelium of the iridoid blood vessels. The function of this barrier helps prevent most proteins and cells from the plasma from entering into the aqueous humor and limit the penetration of the substances from the systemic circulation into the eye. And the third one is a blood retinal barrier, which is the tight junction between the retinal pigmented epithelium cells and the retinal vascular endothelium. The function of this barrier is to regulate the ions, water, and protein transportation into and out of the retina, and to restrict the entry of the large molecules, including many drugs. So let's move to the physiological barriers. For the first physiological barrier is the eye's primary line of the defects called tear film. The cornea itself does not have the blood vessels, and therefore it relies on the tears to bring oxygen and nutrients to the cells of the eye. The gel film is made up of three components, which is the inner mucus layer, which the mucin is produced by the conjunctival goblet cells. This layer helps stabilize the gel film and adheres to the surface of the eye to protect the underlying epithelium against the microbial invasion. The middle aqueous layer is the largest portion of the gel film. It contains the necessary water and nutrients to nourish the eye, which approximately about 60 to 70% of the aqueous part of the gel film is produced by the lacrimal gland, and the rest is from the eyelid gland. And the last one is the outer lipid layer, which is produced by the meibomian glands. This layer prevents the evaporation of the tears. The instability of the balance of this tear film can result in the higher tear turnover rate and increased linking from the corneal irritation, and therefore it decreases the absorption of the topical drugs also. And the second physiological barrier is the tear drainage. There is a study already show that the surface of the canine eye can hold fluid just only about 31.3 microliters, and one drop of the topical ophthalmic drugs is contain about 35 to 50 microliter, and therefore that one topical drop is more than enough, and two drops are excessive, wasteful, and increase potential of systemic side effects. In addition, the tear volume returns to its normal size within 2 to 5 minutes after drug instillation. Thus, the topical of the drug delivery interval between the two drug consideration should be about 5 minutes. For the excessive volume, the rapid clearance of the precorneal area by lacrimal and to the nasolacrimal duct further reduce the contact time between the tissue and drug molecules. This in turn lower the exact time of absorption and leading to the reduce of the drug bioavailability in the cornea. So, in the next topic, I will move to about the routes of the ophthalmic drug administration. The route of ophthalmic drug administration can be varied depending on the target tissue you want the therapeutic drug to be reached. The picture demonstrated available routes of the drug administration to the eye in humans, but only the red squares are commonly used in the veterinary ophthalmology, which is the topical one, and the subconjunctival, retrovulvar, and systemic. And the other one is that the intravitreal, which I never done it before too, but it's also available in veterinary medicine. When it comes to the choosing of a proper ophthalmic treatment strategy, the practitioner must choose a drug and routes of administration that allows the drug to penetrate into the target tissue, to maintain therapeutic drug level in the target tissue for a reasonable time, and has the least severe adverse effects on the target tissue and systemically. So the first route is the topical administration. This route is the most common route of the ophthalmic drugs. The advantages of this route are its non-invasiveness and ease of drug application, minimization of systemic side effects, and maximization of the drug concentration in ocular tissues. However, the disadvantages are also the availability of the topical administered drugs is reduced by the precorneal factors such as the solution drainage, tear dilution, tear turnover, and increase of the lacrimation. Following the topical application, the lacrimation is significantly increased and leading to the dilution of the administered dose. This in turn lowers the drug concentration, leading to the diminishing drug absorption. And the target tissue of the topical routes are the conjunctiva, cornea, anterior, and the lids. To reach the desired therapeutic efficacy, the factors can be the high drug concentration in the target tissue, the adequate frequency of drug administration, the suitable drug formulation used and sequence of the application, and the proper placement of the topical drugs to the patient. Which the sequence, as you can see, ranking to the solution first, after that the suspension, after that is gel, and the last one to be applied is the ointment one, because it's the absorption of the drug. For local administration, the subconjunctival injection of drug is performed It is done by the injection under sedation or topical anesthesia with a maximum volume not exceeded the 0.5 milliliters for small animals. It is not commonly used but can be used for antibiotics, corticosteroids, or in combination. The drugs are affected by soaking through the sclera, entering into the iris, ciliary body, and systemic through the uveal tract, or it can leaking out at the needle hole and soaking through the cornea. The drug will reach the cornea, anterior uvea, and a little to the vitreous. And the advantages of the technique is the longer duration and higher drug concentration in the anterior chamber when compared to the topical one. The disadvantage are the limited volume of the injection. It can possibly form the scar tissue formation, and it can't be removed once the drug is already given. And for the next one is the regional administration by the retrobulbar route. This technique is performed by injecting the drug into the retrobulbar space. This mode administration of the drug to the back of the eyeball is due to delivery drugs such as the anesthetic agents before the enucleation. However, it is very delicate procedure as it may damage the optic nerve and therefore requires proper empties and equipment to do. And the last route is the systemic administration, such as the oral route or subcutaneous intramuscular intravenous route injection. The drugs reach into the eyes by the hematogenous or the vasculature into the ciliary body and are secreted into the tear film in a very low percentage. Ocular inflammation results in the breakdown of the blood-ocular barrier. So systemic drugs will enter into the eyes. The systemic route is typically most effective for the treatment of disease in the eyelids, orbit, and the posterior ocular segment. So next, I will discuss the clinical use of the ophthalmic drugs based on the commonly diagnosed ocular diseases in veterinary practice. Sorry about this slide. There's no conflict of interest here. Okay, so let's begin with the most popular ocular diseases in veterinary practice is the ulcerative keratitis or corneal ulcer. The clinical signs of the corneal ulcer can be varied depending on the severity of the ulcer, and the common signs are like the blepharospasm, epiphora, conjunctivitis, like the third eyelid elevation, because all of this is the painful of the signs of the eye, the corneal edema, and the presence of the ocular discharge. The diagnosis can be done by the fluorescence staining, and I suggest doing a thorough inspection of the ocular surface and NSI at the same time. The corneal ulcer is the loss of one or more layers of the cornea, and this damage the corneal epithelial cells secrete the inflammatory cytokines to enhance the corneal wound healing process, and resulted in the degradation of the corneal stroma collagen to remodel the corneal structure to be back to normal again. The treatment goal of the corneal ulcer is to eliminate or prevent the infection, accelerate normal corneal wound healing, and treat ocular inflammation. So the first drug most of us consider to use in the corneal ulcer treatment is the antibiotic, right? The consideration of the antibiotic of choice are from the suspected contaminant or contaminant risk, the culture and sensitivity results if available, the ability of the drug to penetrate the tissue of interest, and drug concentration within the corneal stroma. And the last is the species, age, or breed-specific consideration, which I will discuss later. And on the right-handed table shows the antibiotic effects to the microbiome, and the pink highlighted demonstrates the availability of the antibiotics in ophthalmic formulations. The recommended antibiotic used in dogs and cats are in this slide. Like for dogs, the triple antibiotic are recommended for use in the prevention or in the uncomplicated superficial ulcer. But if it's more severe or deeper ulcer, you may consider to use like tropamycin or gentamicin. And if that's presenting like the melting ulcer or corneal melting, you can consider to use the higher generation of the fluoroquinolone ones that should be considered. And for cats, the oxytetracycline and fluoroquinolone are commonly used. And try to avoid the triple antibiotic in cats due to the neomycin anaphylactic reactions that can cause some cats to be fatal. The frequency of the topical application of the antibiotics depends on the severity of the corneal ulcer, which can be varied from 4 times daily to every 1 to 2 hours. And if, like I said before, if the corneal melting or keratomalacia is presented, the anti-collagenase is also considered in addition. This drug helps to stop the melting effect of the collagenase and protease on the corneal stroma collagen. This example is like the anti-collagenase, such as the autologous serum that contains microglobulin, which is the anti-protease, and also the acetylcysteine or NEDTA, which both effective against the matrix metalloproteinases, which is the enzyme that destroys the stromal collagen and can stop the melting process. For the frequency of the topical application can be 4 times daily until the corneal melting is completely healed. However, the medical management of melting ulcer is only about 55 to 80% successful, and therefore the surgical management such as the third eyelid flap for corneal protection should be performed to maximize the success rate. For the other topical ophthalmic drug used in the corneal ulcer, such as the tear substitute or the cyclophysic eye drops, I will discuss later in the other topics. But for the systemic drugs, the doxycycline is very useful, not because of the e-kinase, but because of this drug can inhibit the matrix metalloproteinases, similar to the effect of the natural tissue inhibitor of metalloproteinases inside the cornea, and resulting in the inhibition of the corneal melting process also. Okay, so for the next ophthalmic diseases is the uveitis. The uveitis is the inflammation of the uveal tissue, which is comprised of like the ciliary body, iris, and choroid, all of which is the vascular layer of the eye. And the clinical side includes like the ocular discomfort, epiphora, aqueous flare, corneal edema, iritis, conjunctival hyperemia, hypopyon, and hypema, and so on. The diagnosis can be done by the visual inspection of the interior of the anterior chamber of the eye and to intraocular pressure measurement to the value less than 10 millimeter mercury, which is the clinical size of the uveitis. For the uveitis, is the inflammation of the uveal tissue of the eye. The uveitis can be seen to understand like this illustration. The inciting event or trigger is at the top of the figure, which is the red arrow one, and the cause of inflammation proceeds in the circular counterclockwise direction. At the center of the diagram depicts the blindness or the end-stage inflammation of the eye, and also known as the phthisis bulbi. The chronic uveitis can be spiral in the orange line from the outermost border of the diagram towards the center. And if the uveitis resolves in the EQ phase, the trajectory has a green arrow out of the inverse spiral, and the condition is now quiescent. But it's still continuing into the center. It can be more difficult to eradicate the inflammation process, since the eye can act as the reservoir of the inflammatory mediators when its inflammation is ramped up. So the consequence of the ocular inflammation may be vision threatening. And the treatment goal of the uveitis is to control the inflammation and pain by using the topical anti-inflammatory medications such as the corticosteroids, non-steroidal anti-inflammatory drugs or NSAIDs, and the cyclophysic drugs. The same systemic medications can be used if necessary, especially in the severe inflammation, but the systemic use can be contraindicated in the systemic disease infection or other systemic disease such as the diabetic mellitus are present. So the drug that we use at the first is the topical corticosteroid. The example is such as the dexamethasone sodium phosphate, prednisolone acetate, or retoprendol are considered the drug of choice in this UA list. They stabilize the blood-aqueous barrier and decrease the exudation, scarring, and cloudiness of the ocular media. The indication of use are the anterior segment inflammation, immune-mediated disease, to decrease the corneal vascularization and melanosis. And the contraindications are the increased risk of infection, worsened corneal ulceration. It can induce the ocular feline herpesvirus reactivation in cats also. And the frequency or long-term administration, it can disrupt the diabetes management and cause the reversible adrenocortical suppression. So the topical steroids should be given in every case of the uveitis with an intact corneal surface. And the frequency of administration initially should be about 4 times daily, and then gradually taper over the following weeks in line with improved clinical signs. And the other drug of choice is the topical NSAIDs such as the flurbiprofen, diclofenac, or naporfenac that may be applied topically alone or synergistically with the corticosteroid. The inhibition of cyclooxygenase pathway and to inhibit the inflammation, and their effects are similar to those of the corticosteroid to reduce the inflammation inside the eye. The indication of use is the anti-inflammatory drug of choice for diabetic patients, and the contraindication of use are less potent, anti-inflammatory than the corticosteroid, and can increase intraocular pressure, delay corneal wound healing, and are associated with the corneal melting in humans. The frequency of administration can be about 2 to 4 times daily until the ocular inflammation signs is already gone. For the cyclophytic drugs such as the atropine ophthalmic solution, it acts to relax the iris sphincter and ciliary body muscles and providing relief from pain, and it stabilizes the blood-aqueous barrier. The indication of use are the cyclophytic and pain relief, blood-aqueous barrier stabilization, and the prevention of the synechial formation. The adverse effects of the drug are increase in the ocular pressure, which should be avoided in glaucoma, and decreased tear production, which also should be avoided in dry eye patients. It can cause a hypersalivation and occasionally induce vomiting in cats. And the frequency of the topical drug can be about 1 to 2 times daily, according to the severity of the inflammation, and then taper off in line with the clinical responses. For the caution of use of the certain drugs in the presence of comorbid conditions, such as in the corneal ulceration, it should be avoided with the topical steroid, as all you know. For the glaucoma, it should be avoided with the topical atropine, and systemic infectious disease should be avoided with systemic steroid. And the pre-existing conditions, such as the renal disease, should be avoided with systemic NSAIDs, and diabetes should be avoided with the systemic and topical steroid. Okay, so move to the next ocular disease is the glaucoma. The clinical signs include like the episkeletal vessel congestion, corneal edema, anisocoria, or fixed undilated pupil. The diagnosis can be performed by using the tonometry to measure the intraocular pressure. The intraocular pressure elevation more than 25 millimeter mercury with the clinical sign presenting is considered of glaucoma. Note that carefully interpret the intraocular pressure value in the excessive restraint or digital pressure on the eyelid or the jugular vein, which can cause abnormally high in the intraocular pressure value. So the disease of glaucoma is the imbalance between the intraocular intraocular pressure is the imbalance between the increase of the aqueous humor production and the decrease of the aqueous humor outflow. The treatment goal of glaucoma is to decrease the intraocular pressure by decreasing the production or increasing the outflow, logically, by using the medication, surgery, or both together. And other than that, you can choose to preventing medication to prevent the complications such as the exposure keratitis in case of the Barthelmy glaucomatous eyes. So the first drug of choice is the carbonic anhydrase inhibitor such as dorzolamine and brinzolamine. It is used to decrease the aqueous humor production by the inhibition of the carbonic anhydrase enzyme, which catalyzes the conversion of the carbon dioxide and water to carbonic acid and which dissociated into the bicarbonate and hydrogen ion. The bicarbonate is required by the ciliary body cells to produce the aqueous humor, so the decrease of the bicarbonate is leading to the underproduction of the aqueous secretion, and therefore it lower the aqueous production. And this is considered the first choice of the anti-glaucoma drugs in dogs and cats, and because it is the only minimal adverse effect of drug that used is the local irritation in some cases. And the frequency of the topical application can be 1 to 4 times daily to desirable control of the intraocular pressure. The second choice is the use of the beta blockers such as the timolol maleate, which is the non-selective beta antagonist, beta-solol, which is the selective beta-1 antagonist, and timolol in combination with dorzolamine. This drug can decrease the aqueous humor production by blocking the beta-adrenergic agonist receptors and preventing the stimulation of the adenylyl cyclase that can produce the aqueous humor. So the contraindication of the use of this drug is in the ocular cardiovascular disease patient. And the frequency of the topical application can be 1 to 4 times daily also. And the last group of the topical drug is the prostaglandin analogs, such as the matrofos, travophos, latanophos. The increase of they are all increase the aqueous humor outflow, mostly in the uveoscleral pathway by inducing meiosis and opening of the iridocorneal angle. The contraindication of use is the lens subluxation, secondary glaucoma from uveitis, and ineffective in cats. The frequency of the topical medication can be also 1 to 4 times daily to the desirable control of the intraocular pressure. And for the last one is the systemic use of the hyperosmotic agents such as 20% of the mannitol. It is given in the intravascular route at a dose of 1 to 2 grams per kilogram within 30 minutes. The intraocular pressure reducing effect shows within about 45 minutes to 6 hours, and indication for use is in the acute glaucoma cases, and the contraindication of use like the cardiovascular disease, like the hydration patient, diabetic patient, and concurrent uveitis. So the effectiveness of the medications and how long they can control the glaucoma and maintain the PET vision can be varied between individuals. Since there is also no cure, so once medication begins, it will need to continue for the length of your PET life. But if the topical medication does not work, I'm suggested to do the surgery. There are also the other option to treat the glaucoma also. And the last one is the keratoconjunctivitis vulgaris or KCS or dry eye, which the causa includes the hyperemic conjunctiva, mucopurulent discharge, keratitis with the hyperpigmentation or corneal vascularization, and impair or complete loss of the vision due to the pigmentation or the cover of the cornea, like the presentation before. The diagnosis can be done by Schoenberger test, which the normal level is about 15 to 25. The gray zone is about 10 to 14, and the subnormal is 0 to 10 millimeter in 1 minute. So I already performed measure. And the KCS is the inflammation of the cornea and conjunctiva that resulting from the instability of the tear film. And the most common cause of the KCS is the immune-mediated retinitis. So the treatment goal of the KCS is to regain normal tear levels and relieve ocular discomfort by using tear substitute or the corticosteroid if the absent of the corneal ulcer. For the first to consider in the topical treatment of the KCS is the liposomal stimulants, such as the cyclosporine and tacrolimus. It can reduce the immune-mediated infiltration of the lacrimal gland and promote the mucin production from the conjunctival blood cells. The indication of drug use are KCS, chronic superficial keratitis, eosinophilic keratoconjunctivitis, and other immune-mediated ocular surface diseases. In addition, it decreased the corneal vascularization. It decreased the corneal vascularization and melanosis. And the adverse effect of this drug, it can cause the irritation, and if the prolonged use, it can potentially cause the carcinogenic. And the frequency of the topical application can be 1 to 2 times daily to the desirable effect. For the tear substitution can be classified there are so many things in the market. It can be classified by their atomic formulations, which are the artificial tear solutions, which is commonly contain the polyvinyl alcohol. They are useful for removing debris and mucus from the ocular surface and require the frequent application about every 2 to 6 hours to achieve adequate lubrication. The second choice is like the cellulose-based solution or gels, and the viscoelastic production such as the hydroxypropyl, which is the cellular base, and the hyaluronate, which is the viscoelastic product. They have a more viscous texture and slower evaporation times, so it can require less frequent application, about 4 to 6 hours. And the last formulation is the artificial tear that contains the petroleum, mineral oil, or lanolin that called the ointments. They are the most viscous product that provide long-term lubrication but can result in debris accumulation. They are best suited for the patients with lipid gland deficiency, lack of thymos to prevent the exposure keratitis, and the owner who will be absent for a long period of time and unable to topical frequently. The frequency of this drug can be about 1 to 2 times daily, or just use it before bedtime to desirable effect. And the next one I will have a little bit adding up is the topical medication for diagnostic purpose. The drug that can use in the clinic, like all the private clinic, I encourage to use this to have some of them. The first one is the topical anesthetic drug, such as the Detaquan one is very useful. It's blocking the sodium ion channel and required for the initiation and conduction of neuronal impulse, and therefore it decreases painful sensation. This drug I recommended to users only for diagnostic, not in usual in the treatment. The indication of use are for the corneal anesthesia for diagnostic and the minor surgical procedure, such as the manual epilation that Dr. Nalini mentioned before, the nasolacrimal drug fetching, corneal debridement in indolent ulcers, and the use for before the corneal ultrasound, the ocular ultrasound. The contraindication of use are that it inhibits corneal epithelialization and it is toxic to the normal corneal epithelium, and therefore it should not be used for just pain control in the long term. And the next drug is the topical mydriasis drug, which is the topical mide and the phenylephrine. And I will use these two for the diagnostic examination. For the topical mide, the drug is affected by the pupil muscle relaxation and then it dilated the pupil. The indication of use are to mydriasis, of pupil dilation for very short diagnostic procedures such as the lens or funding examination. And the adverse effect of the drug is the increase of the intra blood pressure, which should be avoided in glaucoma patients. So before use of this drug, I encourage you to measure for the intra blood pressure first. If in the normal level, you can use this drug to do the pupil dilation and then have the further examination. And the last one of the topical drug is the phenylephrine, which is the indication of use to localize localized deletions of the Arnold syndrome, and also help the mitosis augmentation in dogs. The adverse effect of this drug is the systemic vasoconstriction and cardiac arrhythmia. And maybe you should try to make sure that if the preparation is also have very different concentration, about 2.5 or 5 or 10%, you probably have to dilute it before to use. Okay, so I have like a little bit of take-home message for my presentation today. When using the topical medication with our clients or our patients, I have to thought about a lot and teach the owner a lot about the compliance of the drugs by making sure that the owner can give the topical drugs properly, and try to convince the owner to put on the E-Cola, and also explaining the potential side effects of the ophthalmic drugs to the owner, especially when using the corticosteroid one. You have to make the owner understanding clearly why we should put on the E-Cola, because if it's scratching causes corneal ulcer, the topical corticosteroid might worsen your corneal ulcer. Okay, and that's all the sum up of today. You should be always administer only one drop of the eye drop. Leave it at least about 2 to 5 or 5 to 10 minutes between drops if the owner is okay. Always will to give the least viscous drug first and to the ointment one to be the last. Drug required in high concentration in the cornea and the conjunctiva are usually best administered by frequent topical application. But in the drug that you need to be penetrated into the eye, to have the high concentration in the vascular component of the eye, such as the choroid, cerebral, uvea, or everything, you should best administered by the systemic route. For the posterior segment disease, that is must be treated via the systemic route only. Do not use the ointment formulation in case of the deep ulcers or corneal rupture, and before or following intraocular surgery to avoid accidentally oil penetration into the anterior chamber, which can induce uveitis. Okay, and that's it of all my presentation today. I want to thank you, WePath and Chiang Mai University.